Hello everyone, welcome to the third of the big debates. I see that you're sprinkled everywhere. I could urge you to move closer to the front if you're so inclined, but if you're happily in a seat that you're happy with, by all means stay. I should introduce myself. My name is Ross Stevenson, and that'll be of an issue of little consequence to anyone here. My job is that I present a talk radio program at breakfast time every weekday morning on a station called 3AW. That is not all that I've done with my life. It is, for the first 10 years of my life, I was an ambulance chasing personal injuries lawyer, which means no doubt I'm very much amongst friends. It does, however, also mean that I'm probably the only person who's been able to improve their social standing by joining the media. We are having a debate today on a subject that I know little about, but as it is intended for the benefits of the ultimate end users of screening, that is to say, the general public. As a member of the general public, may I say thank you for caring enough. The first thing I have to tell you to do is to download the WCC app. I hope I've got those letters right. It is, and maybe for the first time in history, an audience is going to be asked to make sure that their mobile phones are turned on. Download the app. What you need to do is, once you have downloaded the app, go to the section that says live voting, because we have two questions that our debaters have determined we should ask today. It gets a little technical to tell you what you must do once you get to the app. It's not too bad. Your username will be the email address that you used to register for the conference. That is your username. And your password is the number on the lower left of your ticket on your lanyard around your neck. There is a number there on the lower left. That is your password. So the username is your email address that you used to register for the conference, and the password, the number on the lower left of the badge around your neck. When can you vote? You can vote at any time. You can, if you've got a firmly held view that's not going to be swayed by either of our debaters, you can vote now, or you may want to listen to the arguments and vote at the conclusion, because at the conclusion on these screens we will be publishing the results. You will see once you get there that the two questions are as follows. Can informed consent be obtained without an individual approach? And the second question is, are broad public campaigns for screening ever justified? Our debaters are going to speak for 10 minutes each. I might then ask some quick questions, invite them to ask some questions of each other, and then invite questions or statements, brief please, from members of the audience. You will see that in the aisleways there have been microphones set up for that express purpose. Cancer screening, individual decisions or population approaches is the subject of our debate today. Our two debaters I introduce arguing for individual decisions is Professor Julietta Patnick, CBE, Director of the National Health Scheme Cancer Screening Programs from the Directorate of Health and Wellbeing, Public Health in England. Please welcome her. And arguing for public awareness campaigns is Rengaswamy Sankaranarayanan from the International Agency for Research on Cancer based in France. Welcome, Sankar. Julietta will speak first. I don't think having spent some time talking to them and having determined that they have an enormous amount of respect for each other and have known each other for a long, long time, I don't think we should have any expectations of this debate being a bloodbath. But Julietta, your 10 minutes.
Thank you very much, Ross. Thank you very much to the organisers for inviting me to visit Melbourne, which is a terrific city. So I've been asked to argue in favour of individual decisions. And as I'm sure you're all aware, if you're sitting here and interested in this topic, consent to screening and informed consent to screening has been an absolutely massive issue over the last few years, and the information that we give to women in breast screening in particular has been a very hot topic, but it's not just centred on women and breast cancer screening. I'd like to start by looking at what information we do give out about cancer screening. We have to talk about the purpose of cancer screening and the chance of somebody having the disease we're screening for, perhaps what risk factors, so they can judge their own personal situation, whether they have a lot of risk factors or none. We have to tell them about the benefits or disadvantages of screening, and they can then think about them in terms of how they apply to them and their body and their values. We have to, of course, tell them what the screening procedure involves, and they may have some questions about that. We have to tell them how they're going to get the results, and also the meaning and implications of those results. And maybe they think, well, I'm going to be away, I don't want this, or I can't cope with this just now, there's so much going on in my life, or no, I can, that's not a problem, I'll go along. So we give the information out, but for each individual, it has to be related to their situation, their circumstances, and their values. And of course, for those with an abnormal result, we have to tell them what the likelihood is of cancer being there and what happens next. And if they have to come back for further tests, again, we have to talk to them about what those tests are and the meaning and implications of the results. And it might be different for each person. We can give out global information about this is what we do in these circumstances and this is what we do in those circumstances. But at the end of the day, we're dealing with individuals. And while we may say the chances of this happening are 70% and we reduce your risk of dying from the disease by 25%, it's 100% of that individual who is affected, not 25% or 70% of them. So everything that we say globally has to come down to that one individual at the end of the day. So when we're communicating with a target population, whether it's women 50 to 70, men 50 to 74, whatever it might be, the challenge for us as deliverers of services and organisers of services is to deliver a very complex mix of information which we have to make interesting, helpful, and actually high quality. We have to give them accurate information. And when we're dealing with an entire population, you're dealing with, university professors, maybe not in our field, but, fairly intelligent people. And at the same time, you've got to give a degree of informed choice to the woman who can't read when she's invited for breast screening, or the man who just thinks PSA testing is a good idea because he read about it in a magazine or his wife read about it in a magazine. And it's impossible to satisfy everybody all the time because each person needs a different amount of information to make their own informed choice. Several countries invite people for screening by a personal recommendation from a physician. That does rely on attendance because if they never go to see the doctor, they never get the recommendation. But when they do go, that physician knows them and can take account of their background and can frame the recommendation to screen in the appropriate context. So the example I've given here is somebody saying, your father died from colorectal cancer. So that person will be motivated to go for bowel cancer screening. Or you can have a test locally, or you can go to a different hospital from the one that your mother died in, because the physician making the personal recommendation knows the background and knows the individual and knows their concerns. And all the evidence shows that the recommendation of a trusted professional is the most influential thing for an individual. In my country and in many others, we send individual postal invitations. We do need demographic data to do this. People have to have a stable home with an address, but then we can tailor the invitation to the age of the person invited and the circumstances. So we can welcome people to the first invitation to screening. We can say, now you're 50, you need screening every so often. We can personalize it and localize it. In your area, 70% of women go for breast screening or whatever it is, and make it very personal to them to help them make their decision. These days, we shouldn't ignore computer-based information, and this can be very individualized. Even if the facts are produced without any particular individual in mind, Each person can navigate their way through the web as an individual in ways that, as people sitting on the other side of the desk, we don't always understand. And often things that are said are forgotten, whereas things that are written down can be revisited if somebody's forgotten them or doesn't quite understand them first time around. And there's lots of decision aids now becoming available to help people with their decision about whether to go for screening or not. So you can work your way through the decision aid at each stage, judging the facts presented against your own circumstances and your own values. Admittedly, though, it does require somebody to have access to a computer and to want to use it in that way. So I'd like to just think a little bit about what we mean by consent. Well, a person attends for screening willingly. Nobody makes them go. Nobody says if you don't go for screening, you lose your social security or you get fined or something. They have to understand that screening has potential benefits but also potential harms. And they also have to understand that screening can be the start of a journey. It can lead them into a cancer diagnosis. Somebody said earlier in this conference, it's a process, not just a test. And they do need to understand that and not just pitch up, have blood or a sample or whatever it is taken and think nothing more of it. It can be the start of quite a complex series of events. I'd like to show you a couple of posters now. I've argued for individual approaches. Now I'm going to argue against population approaches. What is this? This is from my country. We don't have a prostate cancer screening programme, but this has been a campaign run by the NHS in London in October, November this year. And what does this say to you? If you read that, that looks to me like encouragement to go and get a PSA test. If you're a black man, that would quite possibly frighten you, because 1 in 4, well, there's 4 of us on this street. Which one of us is it? It has no obvious symptoms. If you want to discuss your personal risk of prostate cancer, visit your doctor. And when you go to your doctor and say, I'm a black man, I've got a 1 in 4 chance of getting prostate cancer, what do I do about it, doc? What's that doctor going to say? He's going to say, PSA test. Or if he says, as my programme recommends, well, there's advantages and disadvantages, and here's the information, and I want you to go away and think about it. That guy's going to go home thinking, what on earth is going on? On the one hand, the NHS is telling me to go and talk about my risk with my doctor, and my NHS doctor is then saying to me, go away and think about it. It's not always the right thing. So what purpose does this serve? Now, this one is from Alexandria in Virginia. And you've got to hand it to the people who organise this. They've got some money to provide free mammograms. I presume they mean female residents. I actually took a photograph of this in the ladies' loo in a restaurant in Alexandria. So, congratulations to the people who've organised it, that they're providing this service. But look at this. You're eligible for this free service if you need a mammogram. Who needs one? Women over 40 should have one every year. Where's the harms? Where does it say? Call today to schedule your free mammogram. For you, for them, for life. Where's the risks and potential disadvantages? Where's the fact that it's the start of a journey? Are women who get a free mammogram because they have insurance which does not cover screening mammography, or no insurance, what's going to happen if they need further investigation? Where's the informed choice with this? That's a mass population campaign. So the other thing is, with individual invitations, we have been able to address in my country the inequalities in coverage. We still have them. Our inner cities, you can see the white areas, very poor, and the darker areas, we get better coverage. Without individual invitations and tailoring it, we cannot address this. We've only managed to address it as far as we have because we have been able to go on an individual basis. Mass population campaigns, which we had in the past, we only had screening for middle-class educated women. Individual approaches are the way to get your population in, to address inequalities, and to get true informed consent. Thank you.
Thank you very much, Julietta. Now Sankar to take a contrary view.
Thank you. Thank you, Rose. Thank you, Julietta. You are my friend, my good colleague, okay? So I am going to say, both the approaches are complementary. In fact, population approaches is very important because one has to inform a large chunk of the population, what is going on. And especially if one takes the situation in developing countries, low and middle income countries, where there are no population listings, there are no citizenship numbers, which are evolving, of course. But it is a large population where it will be very difficult to identify the individuals and then send individual invitations or individual appointments and things like that for screening programs. So we have to rely essentially on population-based approaches which will reach a large chunk of the population at an instant, and by using methods which are very, very attractive. And when you reach a large amount of population by modern methods of communicating with them through posters, through television advertisements, video programs, cinematic themes, and many things, one has to very carefully consider the content of the message so it does not put off people, it does not scare people. It gives a positive message which is culturally sensitive. In an individual setting where an individual advises, there is considerable heterogeneity. X will advise in a different way, Y will advise in a different way. We don't have any control on what they say. But on the other hand, in a population-based approach, where you have a message which is going to be given, it has to be uniform, it has to be standard, it has to be culturally sensitive. There is quite a bit of thinking goes behind this. But on the other hand, I agree, the population-based messages will motivate people, empower people to reach programs, to reach services. But when they reach services, an informed consent process and the decision that they make whether to participate or not to participate is based on substantial detailed information at an individual level. But to lead to the individual level, the decision-making process, population-based approaches are very important. I think from that perspective, population-based measures is very important. What it involves? It involves population-based mass communication activities aimed at changing or maintaining people's behavior for the benefit of individuals and the society at large. So this is very benevolent. It thinks about the society, it thinks about the population, it thinks about social good. Population, population awareness, population benefits, population welfare, and it predominantly uses what we call as the social marketing principles. And in fact, from the 1970s onwards, people have started using the marketing principles to disseminate information education campaigns, information educational messages for health programs. So social marketing is another way of saying information education campaigns. In the context of screening programs, the population-based approaches aim to increase awareness, encourage healthcare-seeking behavior, empower people to reach services. When you think about a low and middle income setting, you are thinking about a predominantly impoverished setting where people have many, many things to do. They have to care for, getting their food for the next day, day-to-day employment. There are many things. So you give an individual invitation, individual letter, and then say you come on this particular day. People cannot keep that the compliance will be very low, in fact. But on the other hand, you have a population-based approach where you disseminate message and the message goes repeatedly in a very attractive way, minimal message, I think it encourages people. It makes people aware. Repeated messages, reinforces. And then on a day which is particularly comfortable or convenient to them, they will go and seek services. And then again, it facilitates informed consent processes. Quite often in the context of developing countries, people always question the informed consent process, ethics, many things people question. And quite often people think, okay, people in developing countries are, not able to understand things. No, it is not. And again, a population-based approach gives a positive framework of mind, and you cannot greatly emphasize harms in a population-based approach because it will put off people. And then when people go and seek screening services where the individual can receive advice regarding what it means, what the screening program involves, what the screening test involves, what are the benefits of it, and what type of follow-up measures should be taken, and all those things are provided. So at that time, it facilitates an informed consent process, whether to make a decision whether to participate or not. So in a nutshell, we'll say, population-based approaches, there is uniform messaging, well thought about messaging. It is many stakeholders sit together and look into the messaging aspects and take into consideration the specific cultural, socio-cultural context and the message. And it is a brief messaging, very attractive messaging. And it also allows, because once the message is out, the population, a video program or a television advertisement and all those things are out, it is widely available for a large number of people. If somebody finds it offending or if it is not appropriate, it will involve furor, and then, the program can be withdrawn or it could be modified. So it gives that opportunity. I think in my view, for the specific prevailing conditions in developing countries, this is the most feasible approach. I think for years to come, in many countries, whether it is in Latin America or in Africa or in Asia, I think it's absolutely impossible to send individual invitations, personalized invitations, appointments, and things like that, and conduct a program. Participation will be very low. If you want to ensure good participation, you need population-based measures. And from a overall perspective, it is intuitively cost-effective and cost-efficient, and offers equitable access to messaging. For example, there are people who cannot read. You send an individual invitation, or you send an electronic message or something. It involves certain specific type of skills on the part of the individual, but on the other hand, this gives an equitable access. And it also facilitates an organized screening program. And in developing countries, it is politically more attractive. People would like to emphasize, the governments, the politicians, the ruling parties, would like to show they are doing good. And this is also important, for people to invest money, to take policies, and to conduct programs. I think it is very important to feel for the government they are doing something. So this type of messaging, population messaging, is politically very attractive. And as I already said, the contents are uniform and allows the contents to be revised. Okay. And I already emphasized, and at the moment, in many places, the social marketing principles are taken into account, so that just like a product comes and marketing takes, to make it very popular and profits come in, even in the health area, the social marketing principles have improved the way the population-based messages are now conveyed. I mean, my colleague Julietta said in England and in developed countries, they predominantly use an individual approach. Even there, if you go and then see in physicians' offices and in public places and things like that, there are attractive posters, informing people, a program exists. For example, this is a bowel cancer one from NHS UK. And in United States, there are a lot of, I have seen video programs in YouTube and things like that, Meryl Streep and asking people to come for prostate cancer screening and things like that. Sometimes even, what she said, in a poster you can have a wrong message. It is quite possible, even in individual programs, one can have wrong messages because there is very little control on what people, an individual conveys. Now, I want to show a practical example via a population-based approach, how it has facilitated participation in a newly introduced screening program through a routine health services in a low-resource environment. This is the state of Tamil Nadu in India, which has a population of 70 million, and it has a target population of 7 million women between the ages of 30 and 59. Where the state introduced in a phased manner visual inspection with acetic acid and lugolcidine for cervical screening, and physical examination of the breast for breast cancer screening. This is after training a large number of providers in primary health centers, beefing up the primary health centers with new facilities, separate wings for non-communicable disease control, and things like that. This was a very important effect, in addition to introducing early detection of diabetes and hypertension and management. And next year, they are going to introduce oral cancer screening along with this package. So this is a multi-disease targeted early detection program. And here, the main message, this is Latin to you. This is in my language, in Tamil, mother tongue, okay? So this is why I said, you don't go in a developing country population, you don't go with English language advertisements and things. Of course, there will be some, but on the other hand, the local language, the local cultures. So what it involves, if you think here, this is middle-aged women, and she's a very famous actress, and this is for cancer of the breast. And it says, in a very simple language, here it shows women discussing about their breast, creating breast awareness. And then there the actress says, oh, if you're above the age of 30 and things like that, it may be nice when you go to the primary health center, have your breast examined. And this is a poster. Every day in the TV it comes in the prime time, it is a flash. And then you go to the cinema, during the intermission it comes in, interval it comes in. So there is constant messaging every day. So this is another one. There are different types of very colorful posters and gives a very positive message. Believe me, because you are not able to read Tamil, but believe me, this is a very positive messaging via, cinematographers and many people were involved, in creating the messages and the posters and videos and cinemas. And this is for cervical cancer. This again, very popular actresses. Different types of posters, it is everywhere. And you see this in buses, in all the buses, in the back of the bus, you have the thing. It is, I think Julietta was telling me, it's unacceptable in the West, because you don't advertise many things. But it is very important in low and middle income countries. There has to be constant population-based messaging. And then not only about the messaging, about simple things, just to show, because people think in developing countries, most of the public establishments are dirty and they don't have adequate facilities and things like that. So these programs also take into account to show what is available at the primary health center, how it is kept, and there is good sterilization available so that they make people understand, it is being done with certain preparations. And people go there and then see themselves and they go and promote others, word of mouth. So there is a cascading effect. So what is the outcome? So this is a program where there is no individual invitation. It is population-based awareness creation and encouraging people to go and seek services in primary care health services. There are 1,380 primary health centers where the services can be obtained. And in the first round of screening, for cervix cancer, for VIA, the participation rate was around 40%. And for physical examination of the breast, it is almost like 45%. In a routine public health setting in a developing country for a given round of screening program, this is probably one of the best participation. You can see in theory, like 70% participation and things like that. This is a reasonably good participation following a population-based campaign for people to go in and seek services in a primary healthcare center. And when they repeat, after 5 years, then again, overall, in a period of time, just like in any screening programs, even in the West, after all these individual invitations and things like that, you have something like anywhere between 30 to 50% participating in a given single round. It is over a period of time, after multiple rounds, the cumulative coverage improves. So I would say, the population-based approaches are probably the most important approaches, particularly in low and middle income countries. And I am sure such type of approaches are very important for socioeconomically disadvantaged populations in developed countries, because there are a large proportion of socioeconomically disadvantaged populations, even in advanced economies like the United States and in every developed country. So these approaches are basically important, but on the other hand, I fully realize this is very complementary to individual approaches. When people go in as a result of your population-based awareness program, social marketing, and things like that, the individual messages that one will receive from the providers will further facilitate the informed consent process, participation, compliance to the sequence in a screening program. Thank you.
Thank you, Sankar. A reminder that we're going to be coming to you shortly. There are microphones in the aisleways there. Please, we very much encourage your contributions in just a moment. A couple of quick questions from me, and reminding you that what I do for a living is I tell bad gags on a radio station. Please, if the questions are ridiculous and or naive, please refrain from laughing. Of those two approaches, which saves the most lives?
Well, I would argue, you could actually argue it both ways. I would obviously argue that my way does, because certainly in our experience in the UK, relying on mass population approaches and campaigns just didn't get the women at risk into the clinics, and they weren't getting screened. So the only way that we got the coverage up was by going individual. Our incidence, of course, certainly of cervix cancer is not what Shankar's talking about in India. But for the UK, population approaches just didn't get the women in. And we were seeing, if anything, rising rates of cervix cancer, particularly amongst younger women, until we started doing individual approaches.
What approach saves the most lives?
I think in the context of low and middle income countries, I would say population-based approaches. Because it is the most feasible approach in such settings, and the message reaches a large number of people. It is much more equitable. And I think not only from a cancer screening perspective, if you look into participation in any health care program, welfare program, whether it is HIV control, whether it is AIDS control, whether it is contraceptive practices, family planning initiatives. So you take any number of healthcare initiatives, the population-based approaches are critically important, and I think that is the one which saves lives. But on the other hand, I agree, ultimately it is followed by individual advices and individual consultations.
And which costs the most money?
Okay, I don't have ready data I'm not a health economist. I think I haven't looked into this very critically, but I would intuitively think the population-based approaches must be quite cost efficient.
What do you think?
I think it depends what you mean by cost effectiveness, because if you're not getting the women in, then the cost per cancer might be quite a lot. I imagine if you've got a very high incidence country, a mass campaign might generate a lot of cancers, but in our country, a mass campaign might be cheaper, but it probably wouldn't be cheaper per life saved or per cancer prevented or found, because you just don't get the response. The only time we've ever had anything like a huge response to a mass event was when we had a celebrity dying of cervical cancer pretty well live on air. And that was a real life situation. It wasn't an actor, it wasn't a story, and people responded to it. But that's extremely unusual. As a generalisation, for us, it's cost effective to send individual letters because that's how we get the people in.
Coming to you, sir, in just a moment. A quick one, Julietta. That poster on the back of the lavatory door,
Yeah.
If 100 women saw it in that form,
Yeah.
and the same 100 women saw it in the form that you would prefer it was in, would there be fewer of them reporting for a mammogram?
Well, we try and practice evidence-based work these days, and I have no evidence on which to answer that question. But
what's your intuition?
I would have. My intuition is that women, if it was for women, would see that poster and have the intention of going for screening and look at that and think, oh God, I must get round to that. But actually getting them to do it, the difference between intention and action, that gap can take some bridging. And that would be my guess. Most women would see that and think, yes, I must get round to it. But very few of them would actually write the phone number down and go and do it. That's my instinct. I would also have preferred it if that poster had had something about, think about breast screening, think about whether it's appropriate for you. But it was, you need this if you're in this situation, without a degree of decision-making that I would have preferred. But I think that the difference between intention and action is quite something with screening, because you've not got any symptoms to worry about. And we all promise ourselves, we're going to lose weight next year and we're going to drink a bit less, and we all have good intentions, but actually doing it is something else.
Question from the audience.
I want to begin by complimenting both of the speakers. I found both of you completely convincing, and it was wonderful. I'm a breast cancer surgeon. I recall in 2009 when in my country the U.S. Preventative Services Task Force came out with new mammography recommendations. My wife said, "What do you think?" I started talking for a while, and at the end she said, "Yeah, but what do you think?" I am struck. I consent patients often for surgical procedures, and we have these detailed consent forms that walk you through it, and even the attorneys at the end of it, they don't even read the forms. At the end they say, "Doc, what do you think?" So my question is, what is the role of this informed consent, and do we actually have that adequately defined? Because I'm not certain that exactly what it is that we're doing, other than letting you know there's good things and there's bad things, and you might have one of those bad things happen to you, but we think there's more good than bad. Can you help me really grapple with this question of what we're really trying to do?
Well, that's where I think you need the individual approach, because the physician, whoever it is, whether it's a breast surgeon or whatever, can give the information, first of all, in a format that the patient can understand, because they know the patient and they know their education level, their understanding, whether they're the sort of patient that wants virtually no information or the sort of patient that wants absolutely everything. And of course, all of us are both of those things in different situations. And the individual patient can say to his or her doctor, "What do you think?" I mean, I've asked that question. I bet other people have as well, because the evidence from the experience of a trusted professional who's sat there so many times is one of the things you want to take into account. And with mass population approaches, you just can't do that. So I think that's a situation where the individual approach really can help, because, depending on the relationship, if it's your wife, the wife can say, "Oh, shut up, just tell me what you think." Again, we've probably, quite a few of us said that. But in a polite way, a patient can ask it of his or her doctor. You can't ask a poster on a bus that question.
Shankar?
Yeah. I think I agree with Julietta. When the informed consent process comes in, I think the individual approach is very important, because in a population-based approach, you cannot list all the harms and benefits and cost-benefit ratios and things like that. But even in an individual approach, in an informed consent process, particularly I can say my experience in low and middle income settings, it is a little naive to think, like within 30 minutes or 15 minutes or so, that you are able to understand and appreciate the entire gamut of benefits and harms, and then make a dramatic decision. So the communication there is very important. For example, in a single visit screen and treat approach, a lady who has never gone to school, who has never had an education, formal education, comes and has a test, and then immediately after the test is positive, then you are going to intervene at the same time. Then you explaining to her, okay, I'm going to give local anesthesia, or I'm going to freeze. And then there is, in a point, not 1% chance of you dying. Okay, so I do not want to die. So how do you convey that message? You have a problem, and this problem, there is a possibility that it may become cancer, and then you may need more extensive treatment. And there is an efficient, effective treatment available at the time. It is beneficial, but sometimes there could be complications. And we have the means to manage those complications. And we also say, in many situations, I used to say, if I had a sister or my mother or somebody had a similar problem, with all the knowledge that I have, this is what I would do. And quite often people question this, oh, are you prompting them? Are you, in a situation that the way that you approach this issue is very sensitive, the way you communicate, the way that you empower and encourage people to seek an intervention, rather than scaring them and saying that, exaggerating the harms. I think the harms are very few. If you take any medical intervention, the harms are fewer than the benefits. I think this message has to be conveyed in the informed consent process. And in fact, if you see all the routine programs, whether in Thailand or in Bangladesh and places like that, and in India where the single visit approach is there, more than 75% of the women take a decision to undergo intervention at the same time. And this is something I have found it very difficult to explain to our Western colleagues. Quite often people think, we do unethical things, and you coerce people to undergo interventions. And this is not simply true. On the other hand, you try to explain everything over 2 hours and 3 hours and things like that, and ultimately you leave a person completely confused.
A question from the gentleman on the stairs.
Yeah, Joe Harford from the NCI. I guess my question is related, because it's been said that all screens do harm and some do good too. There is going to be this harm component that's there, and conveying that in a poster, if you have a poster for telling people to stop smoking, there isn't any harm associated with stopping smoking. If you're selling soap, maybe there isn't any harm with selling soap. But here, where you're trying to give a balanced approach as to what a woman should do, given that at least in low and middle income countries, 98 or 99% of the women are not going to die of the thing you're screening for. So the question is, in playing off the two individual versus population-based things, how does one give a balanced sort of picture so that it's not the same as selling soap?
Julietta.
Well, I absolutely agree. It's not the same as selling soap, and it's almost impossible to convey that concept of there is some harm and some risk in this procedure if you're on an advertising hoarding or in a television advert. I have a problem with these social marketing techniques, because they're great for washing powder, but this is a much more complex situation. We're not trying to persuade people to be screened. 20, 30 years ago they did that, but I don't think we're doing that now. We understand better the complexity of cancer screening. I mean, for heaven's sake, colorectal cancer screening can kill people. So this is a very, very complex area, and we have to recognize that. And therefore, the individual approach that can nuance the situation is more appropriate.
Heather.
Is your mic working, Heather?
I don't, it is now. So, Julietta, you talked about going in for individual decisions, and usually that context is always so the woman or the man will be able to talk to their doctor. But how do you know that the response is something that's individualized to the patient, or whether it's individualized to the doctor and whatever she or he believes about screening? And so instead of getting something about the patient and their individual risk, it's sort of, well, I know that they're going to increase the interval to 3 years for cervical screening, but never mind about that, just keep coming annually. Or I know that they talk about risks and benefits of PSA testing, but you know what, just get it done. How do you know that that's any better than something on a bus poster that at least people have had a chance to think things through?
I suppose the truth of it is that you don't, because what happens in the consulting room is between that doctor and that patient, and none of us ever know. And the doctor writes notes down, but that's filtered through the doctor's brain, so we don't ever know is the answer. But what we can do is we can provide information in a balanced, standardized format which is accessible to the health professional and which asks that health professional to these are the facts that you should communicate to your patient when discussing this, that, or the other screening program. And lots of, the American Cancer Society, NCI, we do, lots of organized, I'm sure you do in Canada, have lots of information specifically tailored at supporting the professional in giving balanced information to the patient concerned. And I suppose one has to acknowledge that the doctor might, most of the time, perhaps follow that guidance, but every so often, if he or she thinks that particular patient really needs this screen, they might say, oh, go on, just get it done, because that's what they believe is the best for that particular patient, even if 90% of the rest of the time they're giving out the balanced information the Cancer Society or the health authority actually want them to give out. But we're dealing with human beings. That's our business. So you're always going to have that situation.
A question from the front?
Yes, hello, Bettina Borisch, Geneva, Switzerland. As Julietta mentioned, I think these kind of posters, we have seen them 30, 40 years ago in high-income countries too. There were mass campaigns like that, what I always call Uncle Sam Wants You type of advertising. And we turned away from that. And my question goes to Sankar. Sankar, probably you have been dealing with this question. Do you not think that it is a patronizing way of getting people into something that is a very individual and complex decision, especially if it goes to women that have, at the very beginning, let's say, very little information?
Okay, in a situation where large number of people are dying from advanced disease and with considerable suffering and things like that, where we are trying to change a situation much more radically with the techniques that we know, I think a certain level of persuasiveness in messaging is very important. You take any cancer, which is amenable for early detection screening. 3/4 of the world is suffering from a very high proportion of advanced disease and considerable amount of suffering. I think what are we trying to do? We are trying to reduce this burden as rapidly as possible. And from that perspective, even this very convincing way of messaging is very important. I think I would welcome some of the comments from people like Grasbeck sitting here, like in different in a situation similar to us.
I will go here, then there, and reminding you that your apps should be coming into play shortly, because as we draw to conclusion, we will be publishing the results of those from the front.
Hi, my name is Julietta, and I'm with the Israeli Center for Disease Control. So I'm an Israeli. We have a national program for screening for breast and colorectal cancer. And I actually tend to agree that both approaches are complementary and probably best to use them both. But I have a practical question. In my country, most women are referred to their screening tests by their general physicians. And these poor people usually have, in average, 3 to 5 minutes per patient. And who will give them the individual support or counseling? Because these general physicians will not have the time to do that. So that's one thing. And another provocative note maybe is that, at least in my experience, many of the people, and especially those that we actually reach out for screening, those that are underscreened, are not really interested in all these facts. They want the bottom line. They want to know what to do. Just tell me what to do and I'll do it, if I can reach them and they get to the clinic. So the question is whether this individual approach is more for us doctors and less for them as patients. That's provocative, I know.
A response from you both, starting with you, Julietta.
Oh. Well, as this lady's Israeli, I should probably just argue with her, because that's what your population does. I mean, I appreciate 3 to 5 minutes, you can't have a really balanced, detailed discussion. But you could give the headlines. You could say, this test is to prevent you dying from this sort of cancer or to prevent the cancer developing. And, at your age, you could, you stand to benefit. This would be the risk. Go away and think about it. But if it's included in your insurance scheme, it's probably a recommended test, I would imagine. And for a lot of people, that's the bottom line. If your insurance company or whatever your health authority is that pays for your care includes it in their list of things they pay for, it's probably got some benefit, because most insurers around the world are fairly tight and insist on quite a heavy degree of evidence. So I think you could give the headlines even in 3 to 5 minutes, but you probably would need to supplement it. I accept that. And as far as the uneducated needing a recommendation, you'd have to frame the headline harms and benefits in terms that that person would understand. And you might have to simplify what you say, but you could still give a flavour that this isn't 100% guaranteed success, or that there are some doubtful areas around it. I think you can do that even for somebody who is getting a recommendation. I'd recommend you did this test, but just be aware it doesn't pick absolutely everything up, and it is a dose of radiation, for example.
A quick response from you, Sankar?
Yeah, in fact, I think the population-based approach is very complementary, to facilitate the individual advices in a quick period of time, like 2 to 3 minutes. Because if the population message says, if you have a breast lump, you go to your doctor, but mind you, very rarely it could be cancer, So when you go to the doctor, and then the doctor could say, okay, it could be very rarely, but when I excise this, these are the complications. So I think from this perspective as well, population-based approaches are very, very important.
And the final question from the audience, from the stairs.
Yeah, good afternoon, ladies and gentlemen. My name is Thương Sobi, and I'm coming from Vietnam. I'm CEO and founder of Breast Cancer Network Vietnam. I have 2 questions. Sorry, because last question, but actually 2. I was diagnosed with stage 4 breast cancer 2 years ago. And to get the correct diagnosis in my country, low income and poor country, it took me more than 3 months. And I came to 3 different hospitals, just pushing up the doctor do more tests for me. So at low and also poor country, screening is not enough. And I think that is my individual choice, to put everything to find the problem with my health. That is some information about me. My first question is, in a developing country with very significant stigmas and myths about cancer, attack to breast cancer, which approach would provide a better result? That's the first question. And the second one is, how do you build up treatment capacity capacity before you start broad screening programs. Thank you.
Thank you. Julietta.
Well, I think what I take from your story, which I thank you for sharing with us, is that we should always seek to have informed and empowered patients. It's their body, it's their health, not ours. And whatever decision they make for themselves, we should respect that. And whether that's deciding whether or not to come to screening, to take a recommendation or not, we should never forget that the patient is the focus of care, not the system. The second question that you have posed is the old-fashioned chicken and egg question, I guess. Treatment first or screening first? And for all that I have made my name and spent most of my career in screening, there's no point screening unless you've got decent treatment facilities and adequate treatment facilities. And one of the wonderful things about the HPV vaccination is we don't actually have to make that choice. We can look at these little girls and prevent them getting the disease and needing either screening or treatment perhaps in the future. But I thank you for sharing your story and experience.
Thank you.
Sanka?
I agree with you on both aspects. You know, specifically coming to the second question, I think having adequate diagnostic and treatment services within the health services is a very important aspect of an efficient health service. And it is the responsibility of the national government, national planners, and things like that to invest in the health services to have this available for the population. It's a national responsibility. It is not a donor's responsibility. I think this has to be recognized by governments. This has to be recognized by policy makers and people like that. Once we have adequate diagnostic treatment facilities, adequate buffer capacity within the health services, then you think of having intensive screening programs and things like that, where demand on the health services will be quite high.
Thank you very much.
Thank you.
I guess it's time for us to have a look at the results of the voting on our app, because we're under strict instructions to be out of here by 4 because there's a rock and roll band coming in. I don't know what band it is, but from the people I've seen wandering the corridors, I'm pretty sure they'll all have tattoos. Let's have a look at our very first question. Can informed consent be obtained without an individual approach? If I had superior vision, let me turn around. 60% said no. Can informed consent be obtained without an individual approach? 60% said no. On the second question, are broad public campaigns for screening ever justified? The answer is 96.4%. 4% yes. It's been a great session. We're very grateful to Julietta and Sankar for spending their time and what I think is effectively the last session of the conference. Would you please thank them very much? Thank you. Thank you. And thank you for your attendance.
There is sweetness left unheard.